Hi, I'm Carl Leitner. I'm from IntraHealth International. We're based out of Chapel Hill, North Carolina. We are a nonprofit that's primarily USAID funded. We do healthcare system strengthening outside of the US. And primarily we deal with health workers. And so today I'm going to talk to you about working in a low resource setting, some of the challenges that are present, some of the interesting things that we do here. And we primarily deal with human resource information software. Okay, so IntraHealth has been the lead partner on 2 global projects, the Capacity Project, which ended in October 2009, and the follow-on project, which is a 5-year project. We were just ramping that up, starting the 2nd year right now. And this is a map of where we're working, so you get some idea of where we are. It's a couple months out of date. We have Togo as well. We have Nigeria we're starting to work in. And the color code is the funding, as well as the little icon is where we have the HRIS suite, which is the software that we're implementing. You'll see that it's not in every country that we're working. So this, in a certain sense, this talk is not about the software. It's about working in low resource settings and strengthening health information systems there. So let's just talk about what are some of the implementation challenges and why it's exciting to work in the global health field. There's limited finances. This is kind of an obvious one. This is for hardware and software as well as IT personnel. If you're looking for quality workers, and the Ministry of Health and the country's only able to pay $500 a month, you've got very limited HR resources for IT. So that's one of the challenges that you're facing. You have poor infrastructure, such as limited or intermittent electricity. So if you're talking about national information systems and you don't have power, how does that work? If you don't have internet access and you're trying to pull data from a facility to a district to a regional level office and then to the national office without internet, how do you make this happen on a routine basis? So it's exciting and challenging. And there's very many opportunities here to provide substantial improvements with just a little bit of work. So it's easy to do things. We don't have HIPAA to worry about. There isn't a lot of existing things out there, so you can make contributions very quickly. Okay, so kind of what our goal is with this project in terms of information and information systems is high quality data. And why do we want that? Let's just look at some of the uses of good data for health worker data. Education and training, we want to figure out when we're training people, are we using our limited resources for training to train the right people? You'll see oftentimes that an administrator for a hospital will be going to the same training over and over and over again because they're getting a per diem. So we need to make sure that the right people are going to the right trainings so that they can provide better care to the patients. We also deal with registration, work with different professional councils like nursing councils to make sure there's a qualified supply of nurses that are coming into the healthcare system. And so they register and become certified and then they get deployed. So we need to track the movement from post-secondary education through a certification training process into the healthcare system to make sure what are the gaps in the system, where can we better improve the situation. Management, this is just HR. You want to figure out where the personnel are, how they're moving, et cetera. And planning, figuring out where you need to spend your dollars in the future to make sure that you have healthcare workers where you need at the right time. So one of the solutions that we advocate is using a routine HRIS. So a routine HRIS is one that's used on a day-to-day basis. It's not one that's maintained by a national office that's updated once a year. This is something that's used by a day-to-day basis by a district health office or a facility. The reasons that we do this is that there are lots of challenges with data. The data may exist, but it might be in paper format. It may be held by different agencies and departments that aren't talking with each other. It's very likely to be out of date and inaccurate, and there might not be any standards to really compare the data and share that data. So it makes it very difficult to work with and use, and this is addressed by routine HRIS to increase the value, quality, and ownership. These are just some of the reasons why. Okay. And the goal is to turn data into information. So that's really what we're in the business of doing here. So here's kind of the strategy for the developing HRIS. You have HRIS sitting in the middle. You have a stakeholder leadership, which would include people from the Ministry of Health, from faith-based organizations, from private hospitals, from training institutions. These are your stakeholders. These are kind of defining the data that needs to be tracked by the HRIS. It's also part of a broader system strengthening thing. So you're not just looking at an information system. You're working with building the capacity to deal with this information. So you need to make sure that the money is in the right place and it's adaptable to in-country use, and there's maximal interoperability with other systems. So it's not just HRIS that we're talking about. We're talking about electronic health records. We're talking about district health information systems for disease surveillance and tracking. And we want to make it easy to use. So our solution is we developed HRIS as a suite of software to fill a gap that exists in the public health section. We have HRIS Manage, which is an HR management system. We have HRIS Qualify, which is a licensure and registration tracking system for professional councils such as Nursing Council. And we have HRIS Plan, which is a workforce planning tool to model how many healthcare workers you have and will need over the next 5 to 10 years. And what interventions that you make to the healthcare system will affect that supply. It's free open source software. It's built on the LAMP architecture. It's modular. It's hosted on Launchpad. I can go into a lot of the details. I'm not going to because I don't want this talk to be about HRIS. This is about working in the public health setting and open source software. So in other words, what we're trying to do is we're trying to change this, which this is the Ministry of Health HR department in Zanzibar, and this is their information system before we started, into this. So this is our HRIS appliance. It has, just basically plug it in, you bring a router, you plug this into the local network, and they can run an HR system. Very little maintenance, very little administration needed. It's got a little LCD menu to figure out the IP address and to restart the server, et cetera, but really trying to keep the capacity, the IT needs minimal as we go into these countries and bringing these IT solutions. We have to be very conscious that we're not creating new problems. Okay, so in other words, this is what I'm saying. Let me show you a little video clip. Is this going to work? No, it doesn't. Should be there. No? Okay, hold on. Sorry. Okay, so if you go to YouTube and you just search for Dusty Data, there's a great clip, and it just really tells you what we're doing. It's really showing you.
Network's working better today. You might give it a shot, see if you can just do it yourself.
Do what?
Try going into yourself. The network is working better than it was just now. When I can get back to your presentation, do you have a link?
We got the registry project, as we call it, here at the Nursing Council. This has been supported by the capacity project, which is under IntraHealth. It started in March 2006 with the training of data entrants and examination of the existing data. We were using hard copies. Now these hard copies had every nurse coming in, and it was difficult for you to be able to transform, to know how the exact number of nurses whom we are having as a country. And they said, we are going to enter all this data. We just couldn't believe that we would all get in, that we would get done with it. And it sort of overwhelmed us, and it was all dusty, and it was, I know nobody wanted to touch it, so I said, no, we just have to put on some other clothes to touch this data. It was all dusty.
Okay, so that's what we're dealing with. That's the problem that we're fixing. That's what we're focused on. It's not just HR data that we're trying to fix. We're trying to get this data, these paper forms, into electronic form where it can be used. And I think she can say it a lot better than I can, so I won't try to repeat. Yeah?
What kinds of peripherals, user devices are interacting with this appliance?
So the appliance, it's a lamp. So we set up on the network. There are existing desktop machines. We'll just browse to this. It's all web-based software. And we don't just use appliance. If there's an existing server, we can use that, et cetera. It's just to keep the administration demands down. So some lessons learned. HRIS solutions need to be designed to meet country-specific needs. One size doesn't fit all. So in terms of developing software, it has to be very modular, very customizable. And it has to be, as much as possible, done in country, so it has to be very easy to make these changes. So you also don't want to just jump in and just change the system overnight. You want to adopt existing systems. If they're using paper-based forms, you want to try to model those paper-based forms. It's a higher adoption rate. You don't, and then as they see the use of the data and they have a greater sense of ownership, they can progress further and further. And the stakeholder is very important. If you leave out the stakeholder, if you just come in and say, okay, we're going to do this is going to help you, it's going to be done in such and such way, you're not going to have any kind of buy-in. You're not going to have any kind of long-term sustainability. So it's very important that you start with the stakeholders and you start with them in the very beginning. And this is not an easy process because you have ministries of health that have several different departments that don't talk to each other. You have the faith-based sector, which also provides 40 to 50% of the health care in the country. They don't talk to the Ministry of Health. Then you have the districts, which are basically running independent of the National Ministry of Health, which are doing their own things. And so you have to get all of these together in the same room and agreeing. It's a challenge, and it's a fun challenge.
What countries in Africa are implementing this?
So the nursing councils are in the Qualify software. That's for Nigeria is starting to implement this. Uganda, working in Tanzania, Togo, Ghana, Botswana, Lesotho is coming online soon. It's kind of expanding very rapidly at this point. We're also working in Pakistan, the Nursing Council. And a lot of this work isn't being done by us. We're providing the software, and we may be providing some very basic support, but it's being done in country via consultants or just enthusiastic people at the Ministry of Health. So the recommendations is that we do need to turn this data into information. Just because you can collect this data doesn't mean you should. Lots of times people come in with a list of requirements, and we have to really kind of check with them. Do you really need this data? How are you going to use this? Is this going to help you in the long run, or is it just creating an increased reporting burden? You can't do it from outside the country. You have to be there. You have to work with the people in country. You can't do it as a single group. You really need to work in collaboration. There's other health information systems. There's regional support networks you can work on and leverage. You really need to work within the system, within the country to best affect change. And this gets into where we sit. The Human Resources Information System that is one of the 10 components of a health information system components from the Health Metrics Network, which is part of the WHO. See, there's lots of different components. facility-based services, this is where you can have your medical records. So we've been talking a lot about medical records. It's just one of 10 components in this system. The human resources for health is just one, and the HRIS is just one of these components. So let's just look at some of the ways that you can interoperate and collaborate within this global public health domain. SDMX HD is one data standard that hasn't been mentioned today. We've talked about lots of different standards. This is statistical data and metadata exchange health domain. It's SDMX is based out of the UN, World Bank. It's basically a XML format for sharing aggregate data. And it's OpenMRS, the IRIS software, DHIS, which is the district management software, are all implementing this standard. There's also something called the FIT, which is the Public Health Information Toolkit, which is basically putting OpenMRS or any DHIS, IRIS, lab information systems, logistic management information systems together into one suite. So a country can just adopt the system, just choose the components that they want. They don't have to worry about getting them to interoperate together. So that's kind of where we're working on right now, is really getting this FIT together. And then we have a few unconferences that are coming up. There's an Reach Informatics, and we are sponsoring a Eastern Africa regional conference for ICT capacity building. So looking at introducing all these health information systems, what are the ICT needs for the health worker? How can we train health workers to use electronic health records? What type of IT administration and support do we need from a Ministry of Health? What kind of programmers do we need? So just defining what these requirements are. This is taking place next week at Moi University in Eldoret, Kenya. So if you know your OpenMRS history, this is kind of the genesis of where OpenMRS came out of, is Moi Teaching and Referral Hospital, which is connected with Moi University. Another one that's coming up in the short term is the Western Africa Health Information System Interoperability and Training. This is going to be in Ghana at the end of September. This is WAHO, the Western Africa Health Organization, WHO, Kofi Annan Center, and this is really focusing on building that interoperability piece. I can provide more details if anybody's interested. And let me just finish with how to get involved. So the first part is the ICT capacity building. One way we can do that is Health Information Building Blocks, HIBs. This is something AMIA, the American Medical Informatics Association, has helped coordinate. It's developing little chunks of information that people in country can learn different ICT skills. For example, how to use MySQL, how to use a version control system. So if you're really wanting to contribute, but you don't want to contribute code, this is a great way to just write some little documents and some training materials. Another way to get involved is IntraHealth Open. There's a URL. We're trying to bring open source solutions to health workers in developing countries. We're sponsoring more unconferences, global health fellowships, and we're really pushing for coded in country. So this is kind of like the organic version of global health development, meaning we want 50% or more of the code to be written by local developers. We're not there yet. It's going to take some while. It's going to take some capacity building for IT in the country. So but that's what our goal is. That's what we're running for. We're trying to put ourselves out of business. And IRIS, if you're actually interested in the software, there's a whole bunch of URLs where it's hosted, the wiki, blog, and kind of our to-do list if you really want to get interested in developing on the software. The blog has lots of stories about where we're implementing IRIS or just doing other health system strengthening work. So it's a good place to figure out what we're doing. Okay, any questions? Yeah.
Yeah, OpenMRS is not going to be able to specifically talk about at this conference. Would you mind giving a bit of a summary so everybody knows what that means?
Okay, so OpenMRS is a electronic health medical records system. It was developed it's a Java-based system. It's developed largely to be used in developing countries. I don't know what else you would like me to say about that. Okay.
Just to add to that, it's seen really wide adoption and sort of becoming almost a de facto standard in the
Right. So, I mean, the Moy University, the Reach Informatics, that unconference next week, that's large group of that is OpenMRS people that will be there. So yeah, we were working very closely with them. And let me just say that our HRIS software is also being used in the U.S. It's being used by a network of, in Georgia, they've just started using it, but our focus is outside of the U.S. So we don't have things like payroll and 401k and things like this, but because it's kind of, every country has their own payroll system and every organization has their own payroll system. But so it can be used successfully in the U.S., but our focus is outside the U.S. Other questions? Yeah.
I was going to ask about localization. What sort of, I mean, I assume if you're using it in Pakistan, IRIS has been translated into something other than English, but how's that handled? Is that something you guys do, or do you have people in the field do it, and is it put back in the system?
Okay, so we use Launchpad to handle all the translations, and we have it in Swahili, Portuguese, French, English. And so anybody can go in Launchpad and do the translations. It's hosted within the branch, so they can easily do it there. So sometimes if it's a language that we know will be used a lot, like French or Portuguese, we might pay somebody to do the translations. Otherwise, it can be done in country. Swahili was done in country by University of Dar es Salaam. They have a health informatics program there. Other questions? Okay, thank you so much.